a lot of people want to pursue surgery. Their primary oncologist says absolutely not, which is what I was told when I was first diagnosed. I asked about a pneumonectomy, and I said it's offered to stage one, stage two, stage three. Right now, I have it in my spine, a small lesion in my spine contained to my lung. Like, should we be considering surgery right now before or in tandem with chemo? And I was told it will never be an option for you. And, 6 months later, it was contained, it shrunk in my lung, it's contained to my lung. And I was laughed at by my oncologist when I said I would like a referral to the most aggressive surgeons in California. And I think that is the standard conversation that most people with stage four have. So, outside of bringing in the research that we previously talked about, what recommendations do you have for someone who wants to pursue or consult with a surgeon?
Yeah, I think the most important part is exactly what you're doing is patient advocacy. You yourself as a patient has to be out there talking about this and say, hey, look at me, look at my friend, or look at this person. When patients see that sign of hope and that it actually in real evidence that yes, I'm still alive and I actually had it happen, not a data point, real patient advocacy, real patients undergoing that, like the support groups of young lung cancer, and whatnot. I think that's the key.
Yeah.
That's what patients should do. They need to go to these support groups, talk to them, right? I mean, we've had multiple patients that have come to me after they've talked to you and that we've either
Mhm.
done surgery or considering surgery or in the works for that. So I think that's the way to the best way to do it, because if you go through um, and then they can tell you, oh, well, this is what my doctor said. And then it saves you from trying to wait 3 months for another doctor consultation or
Yeah.
another multiple opinions.
Yeah.
So that's the best way to do it. The second best way, or the second way to obviously do that, and you can do this simultaneously in tandem, is to do like exactly what you did, is to get a few other opinions around. Because like you said, it wasn't like it was your first or second or even third opinion where you eventually got to me. It may have been your fourth or fifth.
Yeah.
And I think in that case, you have to advocate for yourself, not just going to advocacy groups, but you have to be proactive about your health, which you really are. Unfortunately, what I'm seeing, and even in young women tend to be a little bit more advocates for themselves than say the old 80-year-old man, or whatnot. But I'd say even then, there's a little bit there. Not everybody is. They're afraid to. They're being rude, or they feel like they're
Yeah.
being too pushy, or they're being too anxious, or that they should just listen to their doctor. I
I
think
think
that's
that,
wrong thinking. I think you have to be past that. I think we have to get past that. And I still, even now, I'm not convinced that we're past that. I still think people are just kind of listening to their first doctor or their second doctor and being like, okay, I'm good. And or even bad mouth, right? I mean, like you've had that, or on social media, be like, no, why are you talking about this? My doctor said this. My doctor's world renowned. This is what he said. This is what she said. I think you get too many of the closed mindedness or closed offness.
yeah. And I think, women are conditioned. I think there's some like social conditioning to be a bit more, like subservient and likable. And to be likable, you have to be agreeable. And I think that, plays a huge factor in like the patient provider relationship because we don't want to anger our provider. We don't want them to stop
Yeah,
liking us. Maybe that will change our care. So I don't know. I think we have to get over that, like desire to be
100%.
likable. Like, and there's nothing unlikable about advocating and saying, I actually disagree with you, which my oncologists love. I can't imagine if I had an oncologist that didn't seem to enjoy me advocating for myself. Like, despite my first oncologist laughing when I said I want, referrals to the three most aggressive surgeons in California, he did it. And he said, I don't think this is going to pan out for you, but I support you. And that's how every single oncologist has been. Well, the two I've had and the few I've consulted with. So not everyone has that luxury of having a supportive oncologist. So, like, what happens if an oncologist is like, absolutely not? I'm not giving you a referral and I disagree. Like, what do we do?
I've had patients like that have told me that, and 100%, they've either done it on their own without hearing from me, gone to another oncologist and got a second opinion, or I've literally told them. My feeling on that is that's unacceptable if your oncologist is totally like not open to any of that. Especially in this day and age of some of these new consensus documents and things that they have to be open to that. You have to get another oncologist. And I do think that that's when you have to look for a second or third opinion. And if you need help, you go to like Go To for Lung, or you go to other advocacy groups, or you talk to you, or you find, other groups online, but you need to find other oncologists to weigh in. They don't have to be your primary oncologist.
Mhm.
You just have to get another opinion that is a little bit more open-minded. Because if you're at this stage with with an oncologist that doesn't believe in getting truly multidisciplinary, we didn't really touch on that as much. We kind of were, but
Sorry, can you repeat it? I didn't hear what you said. I was coughed.
the key really is multidisciplinary. And so if you don't have an medical oncologist that is open to talking to a radiation oncologist, a pulmonologist, a surgeon,
Yes.
whatever, nurse navigator, whatever, because they think this is the right way for stage 4, which is just give them chemo like we always have, and that's all you need. It's just me or you or me as a medical oncologist. That is
Mhm.
old thinking. That has gone by the wayside.
Yeah.
Now I think first stage, oh, this is going to be a bold statement. This is too bold probably because we're not there yet. But
Mhm.
ideally, my thinking is that right now where we're at right now, finally where we've gotten to is that all stage 3
Mhm.
most people believe that that should be presented. Any stage 3 case, no matter what, should be
Mhm.
presented in tumor board, multidisciplinary tumor board. We
Should
are
what?
definitely
Oh, tumor
stage
board?
3 and tumor board, multidisciplinary tumor board.
Okay. Yeah. Sorry, I
That
didn't
is
hear what you said.
not that is not the case for stage 4.
Hmm.
But I say if I was to look on the other end and say that's where I'd like stage 4 to head.
Hmm.
Like stage 4 should be also reviewed at
Hmm.
tumor board. Right now, more likely the standard is stage 4, medical oncology. We're not presenting to tumor board. We're not getting any other input from a thoracic surgeon or radiation
Huh.
oncologist till way later on down the road.
Even at research institutions? This is everywhere? I didn't know this.
Yeah, most likely.
Wow.
Yeah.
Wow.
Most likely, if you pull that, I would say the majority stage 4 is not presented in a multidisciplinary tumor board
Wow.
setting for lung.
Can
And
you
that's
go into, for someone that doesn't know what multidisciplinary is, and like talk briefly about like why it's important to get all these different perspectives, please?
It's really the most important thing, I think, in the setting, especially for any lung cancer, but specifically if we're talking stage 4 here, is that what is it? It has every different unique specialty that would help you in your care.
Hmm.
Pulmonologists, right? You found them because you were coughing, or not you particularly, but if you had a cough or a pleural effusion, the pulmonologist is involved. Okay, that's one person that's involved.
Hmm.
People forget about this person, the radiologist. The
Hmm.
radiologist helps. Just because you get the read on the CT scan and the PET scan from that general radiologist doesn't specialize in chest, how do you know that that's accurate? You're just going off of them. That's a metastasis to the adrenal. What happens if that adrenal is just maybe just a benign thing, and you just all of a sudden called it stage 4 when it's not? So that's why we have the radiologists that actually see the images that specialize in chest radiology and lung cancer radiology to weigh in. That can help our staging. Can help you the difference between if you're stage 1 or stage 4. What
Yeah.
about a pathologist? You get the biopsy sample. You need a lung pathologist that's specialist in lung cancer to tell you, is it this type of lung cancer? Is there enough tissue? Is the lymph node tissue that you got on staging appropriate or enough? So that's very important. Next, obviously, medical oncology, right? But the tumor board often has multiple medical oncologists from different areas, not just your primary medical oncologist, but experts in the field of lung cancer oncology involved. So multiple different people in medical oncology, not just one medical oncologist. Radiation oncologist, your radiation doctor, different radiation doctors that specialize in different types of radiation. Some do specialized radiation to certain areas. Some do zapping of just one different little area. Okay. And then you have obviously thoracic surgeons, right? Multiple different thoracic surgeons, right? It may be me on there that may be on the more aggressive side, but you also need to hear from another thoracic surgeon that's in that tumor that may say, I don't know, maybe we shouldn't be doing that, or maybe we shouldn't go to surgery or whatnot. So multiple different thoracic surgeons. And then lastly, you have, well, not lastly, there's two others, but often people have an interventional radiologist too that can do zapping, radiofrequency ablation, or burning of things, of tumors in other areas that maybe radiation can't take care of, or that maybe surgery can't take care of. And then you have your clinical research nurse that are involved in that, where at every multidisciplinary tumor board, we technically have this. It depends on what clinical trials your institution offer. We have a clinical trials nurse that'll say, oh, this patient does qualify
I didn't
for
know that.
this clinical trial. Let's
Mhm.
do that. And we have that, for example, on our tumor boards. And so we'll say, oh, clinical trials available, and that's documented too, that if you do qualify for a clinical trial. Unfortunately, for more complex ones, we often don't have that. So then it's up to your primary oncologist to say, hey, at our institution, we don't have these clinical trials, but if you need to look at outside clinical trials, this is, and maybe you'll talk about that separately. This is the hard part is then let's look at outside clinical trials.
Hmm. Hmm.
If
So
your own institution of where you're being presented doesn't. So that's why it's so key to have that. But not everybody's presented in Tumor Board.
I did not know stage 4 was not presented in Tumor Board. I mean,
Yes, it
they've been
routinely is not.
presenting me at mine because he tells me, my oncologist tells me that we'd like discuss this case and that case. And maybe that's because I'm asking about things that are outside the box or
It's
like
absolutely why.
for referrals. For example, I don't think people know they can do this. Um, I had progression. This was, I don't know, a year ago, let's just say, for example. And my oncologist said, I think it's time to start looking at clinical trials. I had one spot, one nodule. And I
Yeah.
said, I can do that, but can we consider radiation? And he
Yeah.
said, I don't really think so. And my response was, okay, but can I have a referral to talk directly with the radiation oncologist to like get their input as well? And he gave the referral, and I had a meeting with them the next week, like through telehealth. So, can you talk briefly about how someone may be able to advocate if they want to talk to another member on the tumor board? How can they do that?
Exactly do what you just said. And I've had patients do that, not just my patients or other patients when I'm on the tumor board because I run our regional tumor board that literally get presented because the patient's like, I want to be on presented tumor board.
Oh,
But you have to know.
so you
You
can
have to
say
know
that.
that there's a tumor board. But
People
you can
can say that.
absolutely say
Present
that
me
in
at tumor board.
100%.
No idea.
Absolutely. 100%. Any doctor, no matter where you're at, community hospital, academic hospital will always have to abide by that because that's also part of cancer on commission credited edition. For a lot of cancer standards at even
Huh.
community hospitals, but definitely academic or cancer centers, you're mandated to have a tumor board available for all patients if needed. Doctor doesn't routinely put you into that tumor because they think your case is standard and we don't need to,
Mhm.
which is not necessarily wrong either. We don't, not every case is presented in tumor board, right? Because that's a lot and you have to, it's only once a week. You got to decide on the cases.
Yeah.
Usually people present 6 or 7 cases a week,
Mhm.
and whatnot. But regardless, you can imagine there's a lot of different cases out there that aren't presented. So that's what I'd recommend if you do want that. And I think it's a good idea to have a multidisciplinary tumor board and to weigh in on like, what does that radiation oncologist think? What does that other thoracic
Yeah.
surgeon think? That to do, hey, I want my case presented in multidisciplinary tumor board. Now, second option, if they don't have a multidisciplinary tumor board and you're in the community and you're like, hey, but I just want to get a different opinion, then you say, whether it's a surgeon or a medical oncologist, radiation oncologist, hey, I don't relate well to this medical oncologist or this thoracic surgeon, or I'm not sure. I want to know my other options. Can I get a second opinion?
Hmm. That's
So
it.
then you ask for
So
that if
easy.
they don't have like a tumor board, but
Mhm.
a multidisciplinary tumor board. But so then that's another alternative route, or you can do and or both.
Yeah.
But either way, those are kind of two ways to get another set of eyes or another opinion.
I mean, can an oncologist say no? Like, what happens if someone says no? They've never said no to me. So, like, are they obligated to say, okay, I'll give you a referral? I mean, I'm guessing not. So, what happens if you
Not
really,
necessarily obligated to, but that's where you have to be your own patient advocate, right? You have to say, no, I'm not accepting that. Like, hey, I want to see somebody else. And then often what'll happen is you hear about patients doing this on the outside of the community. They'll go research it. This happens
ah,
less so with lung cancer,
mhm.
but it happens a lot more with mesothelioma,
Oh,
which is
interesting.
a more rare kind of form, and it's thought to be aggressive. And usually these patients are older and sicker, so a lot of doctors don't even recommend treatment or don't even recommend second opinion. So what a lot of those people do is they go online to find people and they go online shopping. Lung, you don't usually have to do that because it's more common, right?
Yeah.
Second most common cancer, all that. And so usually there's already entities in place for a second opinion or a multidisciplinary tumor board. But if there isn't, or you're not happy with that and you're in wherever in a rural area, that's where the internet's going to be helpful or these support groups or whatever, because you need to go outside of your way to find it if your doctor's not going to do that. They shouldn't.
Mhm.
Uh, Tell you no or all that, but I can't speak for everybody because I'm sure it's different everywhere.
It's unfortunate when, we're tasked with advocating for ourselves after a diagnosis. Like, I just wish the system was different, but unfortunately, it's not. Like, your life may depend on needing to advocate for yourself. Unfortunately,
100%.
yeah.
Unfortunately, yeah. And then that's why we know the whole social determinants of health, kind of, what your background is, education levels, if you're, have a partner or not. We even know based on research, that's what we do know is that certain people struggle or in or different rural areas or whatnot, they don't get the same level of care.
You don't.
And so we do know that's related. So that's why we have to let these people know, that they need to do these other things so they can, you know, um, not be left left behind.
exactly. So I want to go back to what we were talking about, I don't know, 15 minutes ago. If someone's interested in moving forward with a lung removal, they bring the data into their oncologist. Their oncologist says, good luck. You can go find a surgeon. Our surgeon at this institution is not willing to even consider meeting with you. What path can this person take to talk with a few other surgeons and get more opinions? Like how?
That's tough. I mean, the way that I would say, because we're specifically talking about something specific here, which is already very controversial, which is not
Mhm.
necessarily just stage four lung surgery, but lung removal stage four, which is really like kind of avant-garde even more, right? So it's got to be through these things like this. It's looking at these groups. It's talking to other patients that have gone through that and finding out who their surgeon was, and then finding out and then talking to that surgeon. That's the first and foremost way. And the second way, so that's why this is so important, but there's not enough advocacy out there, which is why it's great that you're doing this. Second and foremost, then you got to go when you don't have that, or you don't know if you don't find that, or if you're not like on social media or whatnot, then you do got to go to old Dr. Google, not Dr. Google to find out what lung cancer is or what stage four is, but to find other institutions that are known for cancer, whether it's cancer centers like Memorial Sloan Kettering or MD Anderson or City Hope, or you want to go with academic institutes like Penn or Harvard or UCSF or UCLA, then you got to go your own shopping. And that's what makes it harder. And you've been through that because you don't necessarily know what you're doing, and you're not getting referred. You're self-referring.
Yeah.
Absolutely, you can
But
do
people
that.
can
It's
self-refer, right? You're
absolutely
saying
self-referral.
people can self-refer.
It's just going to
Okay.
take longer and harder, but absolutely, that's what I would do.
Hmm. Okay.
But it's
Um,
ideally situated where when we're talking this specific to
mhm,
find out other patients that have undergone that and then to talk to that surgeon. And then that surgeon,
mhm.
whether or not you come to that surgeon to be evaluated, or that surgeon may know, like Dr. White knew me in
Yep.
Boston, right? Oh, I know Dr. White, or oh, I know that person, or I know that person over in that area. Go and talk to them.
Hmm.
Right, which is
And
how you found me, and that's
yeah.
the kind of way that I still recommend that.
Hmm.
It's different if it's more classic. Oh, I have stage one lung cancer, and you need a surgeon. That could be that's everywhere, but not for what we're talking about.
Yeah. And what steps go into actually like scheduling with a surgeon from another institution? Because I do think that is a bit confusing. It's easier to schedule in your own institution, but if I'm at UCSF, I want to go to Stanford, like what do I actually, like who do I contact? What do I do as a
It's
self-referral?
super hard. That's what it needs to be a whole course on, right? Whether it's
Yeah.
talking to, yeah, that's the issue. That's the hardest part. But what I will tell patients in my naive thinking, and this is what they have to do if they talk to me. That's why, like, we don't even have the resources to tell people how that. That's why I wish we had resources for that, like a nurse
Yeah,
navigator or
I
like a lay
know.
navigator. That would be ideal. Or have, like Matt go too. But not everybody knows to go to him and to talk about that. But so if you don't have all that stuff and you just want to do the plain Jane answer, it's basically you reach out. You have to go to their phone number that's online. So, for example, Stanford Cardiothoracic Surgery has an office line. It's going to be an operator. It's going to be like, a medical assistant that says, "Oh, what do you need?" And you self-refer. You say, "I want to speak with the thoracic surgeons. This is what I have." And then what they'll do is almost every time, okay, fax me over your records, show me your insurance,
Hmm.
all of that. This is how much it's going to cost for a virtual consult or in-person consult.
Hmm.
Usually you have to pay out of pocket, unfortunately, with all this, and it usually takes longer in time, but you start a process, and that's how you start the self-referral process. You actually have to go old school. You call. There is no such thing as an email, or they have an email, but not in the beginning. You have to go and call their office line, the referral line, and go through that whole waiting online or waiting, with the background music and all that. And that's the only way to do that. But that's unfortunate. But the
Yeah.
other way is, oh, I that my doctor knows this person, or I have a family friend, or my son is a doctor. But not everybody has that luxury.
Yeah.
Or you're in the health field like you were. You kind of knew to navigate that. So then you
It
can
was
usually say,
not
"Oh, I
easy
got a buddy."
though.
Even then, it was hard,
It
right?
was hard. Yeah. It
Yeah.
was hard.
Um,
Um, I'm sorry, go ahead. I was going to say something, but I forgot what I
No,
was.
but I was gonna say, like anybody that's out there that has family friends that are in the medical field,
Mhm.
I always urge them to talk to them about it, and to
Mhm.
even if they're not in that field of lung cancer, and they could be a psychiatrist, they could be anything,
Yeah.
but they know the system a little bit and they know other doctors, whether they went to med school with them or they know somebody in that area or they know somebody because they work in the hospital.
Hmm.
Tell them your story. They can help you.
Yeah.
people that are in the medical field, especially immediate family or family friends, they can be
Mhm.
such good advocates,
Yeah.
because they'll push
Yeah.
the doctor that's treating you to really step up their game. And all doctors should step up their game, but even more so when you
Yes.
have people in the medical field that know stuff,
Mhm.
that know about this field and understand things, that will help you get better care. And I'm a proponent for that. I like that because then I can actually, as me as the doctor, the treating doctor, you can actually talk to that, person like really detailed and be like, hey,
Mhm.
you understand this? We're going to do this. We're going to take a note. We're going to do this. Whereas you
Yeah.
can't necessarily get into the nitty gritty with that with the patient, but you can with the family member or the friend that is. So I do recommend that. I think that's helpful.
I think that's great advice generally when someone is diagnosed with cancer is to have an advocate with them. Or like what I tell people is someone that carries a different set of privileges. So if you're a woman, bring a man. If you're a person of color, bring a white person. And like
Hmm.
non-English, speaking person, bring a person that is first language speaking because I think that will help you get what you need in this healthcare system that carries a lot of biases still.
Oh my God, 100%. Like you just said it. The worst, the not the worst, the hardest thing is translation.
Yeah.
People will, if they don't bring a family member and they just use the hotel or that the hospital translator and
Oh,
stuff,
it's
it's
horrible.
never the same. It's never
No,
the same. And so
no.
people have no idea. I wish they really knew that. So that's why you can get that word out. If you don't, if your family member or patient doesn't speak the language or doesn't understand Spanish, Mandarin, whatever, Tagalog, whatever,
Yeah.
German, it's much better to have somebody that you know and not just rely on the hospital translator to do all this stuff when it comes to
Don't
cancer,
rely on that.
especially lung cancer and especially stage
Yeah.
4. You cannot, there's so much that they will not understand. The
Hmm.
patient that gets quote unquote literally lost in translation. And so this may be like
Yeah.
too much. Like some people don't always agree with me with this. I'm all for hospital translators and stuff. It's not the same as if you have a family member, a loved one, a family friend that's translating. Some doctors don't believe in that. They think, oh, well, it's too biased that way. To me, it's different. They have your best interest.
Hmm.
You know what I mean? And they're going to really relay it better. They're going to be at home with you relaying it. They're going to be on the phone. The hospital
Yeah,
translator is just doing it right then and there, and that's it.
exactly. Yeah.
It's definitely not the same. And I've done research on this, like for lung cancer screening. It's just not the same when you don't have a family member or a friend that's translating for you. So that's even work. We won't go into that because that's even
Oh, I have
a
so many
harder.
questions. Okay,
That's a
that's
whole
another.
nother. Yeah,
Okay.
that's another avenue. That's really difficult.
Dr. Vallada, thank you once again for joining me on the second episode of the Wang Lung Lounge. And I really look forward to talking with you again on the next episode.
That was a pleasure, Ashley. Thank you.
Thank you.